Λοιπόν, καλησπέρα και από μένα. Ελπίζω να με ακούτε και να με βλέπετε και ευχαριστώ πολύ για την πρόσκληση. So I will continue in English. Diabetes and tuberculosis is the topic of my lecture, and I think it's a very much neglected and underestimated topic, especially among respiratory physicians. So let's see a bit on the epidemiology of diabetes. These are data from 2019, and there are more than 460 million patients with DM around the world. And you can see the countries where the prevalence is higher, and more than 4 million deaths in people aged between 20 and 70 years old. And the prevalence is increasing, so we expect to have 700 million adults with diabetes by 2045. But which are the countries where DM is more prevalent? One would assume that high-income countries are the countries where the DM is more prevalent, but these countries account for 95 million. You can see that middle-income countries account for more than 300 million of patients with diabetes. So I would say that about 80% of DM patients live in countries of low and middle income, which is a surprise. What about TB? TB epidemiology around the world in 2019, you can see that the incidence is higher in Africa and, of course, in several parts of Asia. We had more than 10 million patients with TB in 2019 and around 1,500,000 deaths. The incidence of TB is decreasing slowly, but decreasing, and that is also the case for TB deaths. However, the targets for TB control set by the WHO will not be met. You can see here, these are the targets, and for instance, for TB incidence, what we expected for is a 20% reduction by 2020, and what we have achieved is a 9% reduction. So the incidence is decreasing, but more slowly than expected and anticipated. And in Greece, we can see that there is also a decrease. We have an incidence of 4 patients for 100,000 population, which again shows that Greece is a low incidence country for TB. But what we should state here is that this is just the reported incidence. In truth, TB incidence in Greece is 3 to 5 times higher than reported because it is severely an underreported disease. So the relation between DM and TB is known since the Roman times, and in the beginning of the 20th century, juvenile DM was associated with a 10-fold increase in TB risk. But this relation was considered of low significance because effective treatment for both diseases became available. And also, this relation has been severely underestimated due to the fact that improved TB control exists in high-income countries, and presumably low TB incidence exists in low or middle income countries where TB incidence is higher. However, the situation has changed over the last 20 years as we have seen the magnitude of DM incidence in low and middle income countries where TB remains a major issue is detected. And also TB's incidence globally is decreasing more slowly than anticipated, and also scientific research on the interaction between these two diseases is increasing. So this is a framework first published about 10 years ago by the WHO, giving a framework of interaction between care for tuberculosis and diabetes. And it says that there should be surveillance of TB among diabetes patients in settings with medium to high burdens of TB, and we will see that more in a bit. And also surveillance of diabetes should be initiated among all TB patients. This is a study from different TB clinics around Europe, and we participated in that study. What this study showed is that among TB patients, DM prevalence is about 10%, and DM prevalence is associated with old age. So the DM-TB interaction can be seen on many levels. So we have diabetes probably affecting development of LTBI, latent tuberculosis, also diabetes affecting the progression of LTBI to active disease, and diabetes affecting and impacting severely on the clinical presentation and outcome of TB disease. And we will see all that in the next few slides. So DM and the natural history of TB, this is a modeling study based on data from India, stating that 15% of TB cases can actually be attributed to DM, which is a huge percentage. And also that the main impact of DM is the fast progression from latent TB to TB disease. So DM and latent TB, these are two studies, and I would like to talk to you about these two studies for a bit. The first one is a meta-analysis of 15 studies, including about 40,000 patients, which showed that there is a mild increase of latent TB risk in patients with diabetes from about 1.2 relative risk. And so there is an effect, but just a mild one. And the other study is about refugees in Atlanta, USA. So 700 refugees who were tested both for DM and for latent TB. And you can see here that for patients who had no DM, LTBI prevalence, latent TB prevalence was about 25%. Among patients with pre-DM, prevalence of latent TB was 39%. And among patients with DM, LTBI prevalence was 43%. So there is an increase as DM progresses, and people with pre-DM and DM had higher risk of latent TB, and the odds ratio was 1.7 and 2.3 respectively. So what are the underlying mechanisms for this higher risk of latent tuberculosis among patients with diabetes? One is the higher risk of exposure, because patients with diabetes visit healthcare facilities more often. And the second possible explanation can be changes in the immune system caused by diabetes, which actually decrease the immunity to M. tuberculosis. But in all, DM effect on M. tuberculosis infection has not been fully elucidated, neither immunologically nor epidemiologically. So should patients with diabetes be screened systematically for LTBI, as we know it is the case, for instance, for patients who are going to receive anti-TNF alpha agents? So the answer to that question is no. Systematic screening for LTBI, for latent TB, is not recommended to people with diabetes, because we don't have any evidence that this massive screening would have a positive effect. So the next step, of course, is the effects of DM to the progression of LTBI to TB disease. And here things are far more clear. And this is a very important, significant meta-analysis published a long time ago, saying that the risk for progression to TB disease in patients with diabetes is 3 times higher versus people who don't have diabetes. So this study included 13 studies and nearly 2 million participants. And what we can see is that the TB risk was higher among people with diabetes, regardless of TB incidence. But of course, as the TB incidence increased, the relative risk became higher. And this is a more recent meta-analysis on the same subject, which included 44 studies from 16 countries. And in that study, what was shown is that DM increases TB risk 3.6 times in 4 prospective studies and 1.5 times in 16 retrospective studies. Also, the risk is 3 times higher in low and middle income countries and 1.7 times higher in high income countries. Also, the risk is higher about 2 times in countries where the TB incidence is more than 50 and 1.9 times higher in countries where TB incidence is below 50. And what is also interesting is that this association is stronger when diagnosis of TB and DM is confirmed excuse me, by laboratory methods. So that when the diagnosis of these two diseases is certain, then the association between the two becomes stronger. The variation of DM impact on TB disease risk is significant between studies. Intervening factors include, of course, glucose level control and age. We also know from clinical practice that TB may lead to a temporary increase of blood sugar levels, which frequently resolved during TB treatment without any treatment for diabetes at all. And it also appears that TB risk decreases significantly within the first 2 years of DM diagnosis. That means that when we have a newly diagnosed DM patient, the risk of TB is higher within the first 2 years from the diagnosis, and then it gets lower. Let's see, these are a couple of studies showing that DM control impacts severely on TB risk. In that study, it was shown that if the blood sugar levels are well controlled, this actually was not associated with any increased risk of TB at all. And in that study, what we can see is that TB risk was higher as complications of diabetes increased. So patients who had more than 2 complications of diabetes had a higher TB risk. This is another interesting study conducted in Tanzania. And here they had more than 500 people with TB and matched controls. And so all these TB patients were actually assessed for DM, but they were referred also, the ones who actually had DM were referred to a DM clinic, but for unknown reasons, nobody started treatment. So what they saw is that DM prevalence was higher in the TB group, and also that most of the patients initially diagnosed with DM did not have abnormal results at follow-up, which was about 5 months after the initial evaluation. That means that blood sugar levels returned to normal just with anti-TB treatment for most of the patients. The International Union Against Tuberculosis has launched this report about a couple of years ago on the management of diabetes and tuberculosis. So what does that say about DM patients and their need to be systematically screened for TB? Is there such a need for every DM patient? The answer is that this depends on the TB incidence of the country. So systematic screening is recommended for every DM patient if TB incidence is above 100 per 100,000 population. So this is not the case for Greece. And due to the high risk of TB during the first months after DM diagnosis, newly diagnosed DM patients should be screened for TB in high incidence countries. Patients who have already known DM should be informed about the risk of TB so that they can recognize the symptoms as soon as they appear. On the other hand, should TB patients be systematically screened for DM? The answer to that question is yes, for every country across the world. So every patient who gets a TB diagnosis should be screened for diabetes. And if such a massive screening is not possible, then priority groups are age over 40 years and BMI over 25. And also patients with high glucose levels should be rechecked at the end of anti-TB treatment so that we can see if anti-TB treatment has actually affected glucose levels or not. Now, this is an algorithm for the screening. So we have a TB patient and diagnosis or registration. The first question is, do you have DM? If they do, then obviously no screening is needed. If they don't, we have a random blood glucose level, and this random evaluation means that we shouldn't let these patients go away and come back. They should be checked for diabetes as soon as TB is diagnosed. So this association between active TB and DM is a very well documented association, and we can see that in the American guidelines or the Canadian guidelines. The risk for diabetes poses on active TB is about 3 to 4 times higher. So what about, we have seen the effects of diabetes on development of latent TB and then on development of active TB. What about clinical course of TB and outcome? Again, this is a very well documented topic. There are lots of meta-analysis on the topic and lots of papers on this topic. And if we want to just give a summary of all these findings, we could say that in people with tuberculosis, diabetes is associated with smaller chance of limited disease, of more symptoms, of higher possibility of fever, of higher possibility of positive stains, of higher chance of opacities or cavitation, of longer time to negativity, of higher number of neutrophils or CRP, of lower levels of anti-TB drugs. And also, it's also associated with pulmonary versus extrapulmonary TB, cavitation, positive stain, with increased risk of death, of relapse, of treatment failure, and of resistance. And this is a very recent meta-analysis on the subject, including more than 100 studies. So people with TB and DM versus people with TB alone have a higher risk of death with an OR of 1.9, risk of relapse with an OR of 1.6, and risk of MDR of around 2. So the impact of DM on clinical course and outcome of TB is well documented. And this is why the treatment duration of tuberculosis based on the ATS-CDI-DSA guidelines takes into account the presence of diabetes. So the treatment is usually 6 months, but it can be extended to 9 months. And one of the reasons to decide to extend this treatment course is diabetes, because if we give a longer period of treatment, then we can expect lower chance of treatment of relapse. Management of TB and diabetes. So drug interactions are a problem. We all know that rifampicin decreases sulfonylurea drug levels quite a bit, and also there are mixed symptoms due to both diseases, and we have drugs, of course, for both diseases, and this combination can also can cause more adverse events. We could have deterioration of diabetic neuropathy. We could have increased risk of liver and renal function abnormalities. Increased drug intake may mean decreased adherence, and also we have a difficulty in control of diabetes because of these drug interactions. A realistic target is to have below weight. So the management of TB and DM, TB treatment on DM patients is the same. We don't change a thing. What we do, we should take into account is for lowering the risk of transmission, that patients who have both diseases should be initially followed up at the TB clinic and after, at least for the first couple of months. So metformin is the first line of treatment because it doesn't interact with the anti-TB drugs. Insulin is an alternative regimen, also in patients with high glucose levels, and those who cannot be controlled by other perros drugs. So in order to conclude, we have seen that DM increases the risk of active TB disease, that it has a negative impact on TB outcomes, that all patients with TB should be immediately screened for DM, that adequate DM control is a main target for TB patients, and that these two diseases interact on many levels: epidemiology, immunity, clinical course, and of course management. Thank you.